Thank you, Sandy. And I'll try to make this a informative and useful presentation for everyone. Let's start with that first. How's it sound now? Much better, good. And also, I think the fact that I'm the first rehabilitation medicine physician to speak from up here will change the kind of flavor of the talk. One of the things that I'm interested in isn't so much what the interleukin-6 level is or what the cells look like. It's, well, what do you do next? What's the next step in terms of treatment? Let's get this right. So let's start off with what do we know about transverse myelitis in children? And as Doug mentioned, when we started this, very little was known about what caused it, even what the manifestations were, and what the outcomes and prognosis were. So what we did was use the experience of the Johns Hopkins Transverse Myelitis Center to collect, in a fairly short period of time, a group of children with TM and then analyze the results of both questionnaires and physical examination information that we had on how they did. And what we're going to look at are those 5 things that Doug talked about: motor symptoms, autonomic symptoms, pain, and sensory system symptoms. So just to start out with, these are the published case studies of pediatric onset TM, and we define that as anyone who develops symptoms of TM under the age of 18 years of age. And as you can see, most of these studies had under 25 cases, and this one by pain, they collected these cases from 1929 to 1952, so over a very long period of time, whereas we were able to collect 47 cases over a much shorter period of time, from the year 2000 to about 2005. So I think the characteristics of this group of individuals was much more constant than a group that had been collected over a much longer time period. So the objective that we start out with of this talk today is to correlate clinical characteristics associated with the onset of acute TM. This is the idiopathic form that Dr. Kerr talked about, with the functional outcomes. How did these individuals do? The measures that we used were chart analysis. We looked at, any information that we could get from their charts, clinical evaluation, which is the neurological exam, and we used something called the Hughes Functional Disability Scale, because this was something that could be applied right away during the acute phase of illness, and I'll show you what that looks like in just a second. And then we were curious to see whether those findings right away had any predictive value 3.5 years down the road, so that we could tell the families of these children something about what might happen later on. And the other measure that we used was something called the Functional Independence Measure. It goes by FIM for adults and WeFIM, meaning small, for pediatric age individuals. And this is a tool that's in very common use among pediatric rehabilitation centers that divides out the various areas of function into 18 different categories and assigns to each of those categories different levels of independence. So we thought that was a very good tool for taking a look at how independent individuals were after getting transverse myelitis. So this is what the Hughes Functional Disability Scale looks like. It's a 7-point scale. It goes from 0, which is normal, to 6, which is death, and everything in between. 1 being minor symptoms, fully capable of manual work, 2 able to walk more than 30 feet without assistance. So we could assign individuals different levels according to the Hughes Functional Disability Scale, both acutely and then down the road chronically when we took a look at them later on. And as I mentioned earlier, the WeFIM is another very powerful outcome measure and for the purpose of this evaluation, we specifically looked at items in the self-care domain. How well could they do things that were classified under the category of ADL skills, or activities of daily living. The mobility scale, how well could they get around in the cognitive domains. Actually, I don't think we did look at cognitive. and this was designed to document functional performance. And, for those of you over there, I don't think you can see this very well, but this is what we call the spider web graph, because it kind of looks like a spider web. And as you go around the circumference of the circle, there are the 18 different categories which the therapist will assign a specific level of independence. And then over here you see the FIM scoring scale, which goes from 1, which is total assistance, to maximal assistance, moderate assistance, supervision, all the way up to a 7, which is complete independence. So for each one of these items, the therapist assigns a number. Participants, we looked at 47 children with acute onset of transverse myelitis. 89% of these cases were the classic idiopathic, monophasic children with TM. Actually, 2 had recurrent cases, 4 had disease associated. So let me take that back. These weren't all purely idiopathic TM. There were a small number with these other categories of transverse myelitis. And then one case, after we did the analysis, developed the second bout of transverse myelitis, and we eventually diagnosed that child with multiple sclerosis. So this is the graph that shows the age of onset of TM. And this part over here, which is this peak between 12 and 15 years, has been published earlier. What was a big surprise to us was we had so many kids in this 0 to 3 category, and we weren't sure whether that meant that only the more severe cases were coming to Johns Hopkins, and therefore we saw more of those individuals, or if there had been something that was changing in our environment that made young children more susceptible to the onset of transverse myelitis. And one example of that might be, although I kind of hesitate to say it, is the immunization schedule of children recently. There's a lot more immunizations that children get now than they used to 10 to 15 years ago. So let's get into findings a little bit here. So the age of onset of ATM in children appear to cluster into 2 groups, as I showed you on that graph, between 0 and 2 years of age, the other 5 to 17 years of age, but more toward the adolescent age group. 18 cases were found that were less than 3 years of age. And when we looked at the published literature, these are all the case series of published cases of pediatric TM. Our incidence of really young kids with TM was 38% versus only about 1 out of 10 in all the other published results. So either those are kids that didn't come to those other centers and were somehow not, in that population, or may represent a new group of individuals who are developing transverse myelitis for whatever reason. We wanted to know, were there any antecedents of pediatric transverse myelitis? Were there any factors that we could identify that predispose these individuals? And what we found was there was a febrile illness reported by the families in about half, in about 47%, confirmed immunization or allergy shot vaccination in about 25%. So about one quarter had the immunization within a month of onset. And then this interesting thing about trauma, about 13%, so 10 to 15%, there was a history of some form of trauma preceding the onset of the transverse myelitis. Acute symptoms. Well, let's take a look at that. So as we said before, pain, a big issue, acutely, 75%. Sensory loss or numbness, almost all, 91%. Autonomic symptoms, urinary dysfunction, 85%, weakness, 89%. So these are a group of children that pretty much presented with the classical findings of transverse myelitis. So now let's look at how did this group as a whole look at follow-up, which is about 3.2 years afterwards. So in these 3 categories, sensory problems, bladder problems, and ability to walk or ambulation motor, a indicator of weakness. What we found was sensory problems. About 54% had the aesthetic findings, the pins and needle sensation, and 75% had numbness. So there was a substantial number that still complained of either painful feelings or numb feelings at follow-up. In terms of bladder problem, about half of this group required catheterization, and about 68% had urgency. Ability to walk, about one-third was independent, about 21% required a walker or other support, and 43% were unable to walk 30 feet. 30 feet. So in terms of a snapshot, this group performed more poorly, had less independence, less functional skills than previously published groups. This is another way to look at that information, and I think if you just take a little while to look at these two bar graphs, it gives you some sense of the change over time between acute presentation and follow-up. The white box at the top are those individuals who walk without help. So as you can see from that small sliver, which is white, only a small percentage could do it acutely, and that increased to about 40% at the time of follow-up. Conversely, the black box is the non-ambulatory individuals on presentation, which you would expect because the most common way these individuals present is they can't walk. They wake up in the morning and they're not able to walk. So over 80%, and that dropped down to under 40%. So, I guess a good thing about this finding is that, even if you're unable to walk or paralyzed at the time of onset, many of those individuals will be able to walk eventually. We looked at bladder management because, as was mentioned earlier, this is one of the most common long-term problems with individuals who have transverse myelitis. And again, if you look at this bar graph, the white sliver here, the white rectangle, is neither the need for catheterization or the finding of urinary urgency, only a small number. And in this case, unlike the previous slide where there was a big increase in the individuals who had the white box or the best outcome, in here it went only down to about, let's say, 20% developed the absence of urgency or developed the need not to be catheterized. The black box here, again, this is individuals who required catheterization for their urinary function. Start off around 50%, and it dropped to about, let's say, about 25%. So 25% of children in our group still needed catheterization. I'm sorry, 25% needed catheterization without urgency, but really about 50% required catheterization and had urgency. So in terms of the group of children that came to our center, about half of them still required catheterization 3.5 years after presentation on average. This is the presentation of the results of the WeFIM and FIM at follow-up. The reason that we did both is some of our individuals were actually adults by the time we got the follow-up information. And in terms of looking at this graph and understanding it, we looked at these four areas: self-care, sphincter function, transverse, and locomotion. These are 4 of the 18 areas on the FIM outcome measure. And in this case, we wanted to know what percentage were independent in those skills, what percentage had modified dependence, and how many were dependent. So as you can see, as you look over those 4 categories, they became most independent at follow-up in the self-care category, and least independent, which is the shortest dark blue box, in this urinary control or sphincter category. So it again is just more evidence, looking at it with a slightly different outcome measure about how an individual was able to function in the long term, and in this case, sphincter function would be bowel or bladder sphincter function was required the most assistance. And then over here, if you look at locomotion, which is how they define that outcome measure, at the time of follow-up, looks like about 65% were able to independently locomote. That's with or without the assistance of a cane or wheelchair. Modified assistance was a smaller category, and there was a very small who were dependent. That means not able to use a wheelchair, basically. Okay, another group of information, some other information that we had available to us was the result of spinal MRI findings, because this was right around the time when spinal MRIs were being used on a routine basis, so we had access to information. So none of the other previous studies on pediatric transverse myelitis really were able to look in detail at the results of MRI findings on the spine in kids with TM. And what we found was this finding right here, which was T1, which is a way of looking at the images on MRI findings. If you looked at the T1 scan, if it was hypointense, less bright, that's the spinal cord itself, those were the ones that had the significantly worse outcomes at follow-up and the trend toward worse continence outcomes. So, you can either see a hyper-intense a lesion that's too bright, which is the one that you've been seeing earlier today, where it lights up, or you can see a hypointense, where it's duller than it should be or darker than it should be. If it's hypointense, we would worry more because of our finding that the outcomes were not as good. Lower level of the lesion on MRI was associated with a better outcome for both ADL skills, which are activities of daily living skills, and mobility, and fewer involved spinal cord segments were associated with better outcome. Of interest was almost all of these children had abnormal findings on their spinal cord MRI findings, which kind of goes along with well, not goes along with, but it kind of is another way that we can look at whether these children really have transverse myelitis or not, because as Doug mentioned earlier, the results of the spinal fluid in terms of white blood cells and the gadolinium and enhancement may not be quite as obvious the younger the patients are. So some surprises as a result of our evaluation. There was no correlation with worse outcome associated with rapid progression to maximum impairment in less than a day. So, we thought, well, if you got sick quicker, that maybe meant that you were more involved and that you would have a worse outcome. Well, that turned out not to be true. So the rapidness of your decline in walking or your other functions did not associate with it. Antecedent illness and immunization did not correlate with a worse outcome. So this goes back to one of our previous speakers. I think Ben said it. Yeah, just because something follows something else doesn't mean necessarily that the two are connected. So even though many of these children had a history of immunization or viral illness prior to the onset of TM, it didn't prove that one caused the other. But what we found out is if one did have a case where there was an immunization or if there was a viral illness prior to the onset of the TM, those individuals did not do worse than the ones that didn't have the onset of those. So that's all we're saying with this finding. And trauma, too. And then we also noted that the patient scores on the Hughes disability scale, when we got them when the patients were at their worst, did significantly correlate with functional outcomes on follow-up for activities of daily living, continence, and mobility. So that basically means that if you look at how someone functions and uses fairly simple 7-point scale, you get some sense of how that individual is going to do down the road. So I think that was a surprise that it had such a strong statistical correlation. These are some variables that are associated with a better outcome in terms of the results of the analysis from our study. Older age at time of diagnosis, you did better. Goes along with what Doug just mentioned, that the younger the child was at time of diagnosis, the worse they did. Shorter time to diagnosis, seemed to correlate with a better outcome. So if you knew that it was transverse myelitis right away, you could institute some kind of therapy. That kind of makes sense. Lower sensory and anatomic levels, the lower in the spinal cord, seemed to correlate with a better outcome. Absence of this MRI finding, the T1 hypointensity, lack of white blood cells in the CSF. When we found that, those children did better, and fewer affected spinal cord segments. So sort of as a summary slide, outcomes from the Johns Hopkins Transverse Myelitis Center, acute versus chronic, in terms of the sensory loss or numbness category. Overall, 91% of our kids had those symptoms. Chronically, that remained in 75% of them. So that was a very common long-term outcome. Mobility loss, 89%, chronically 64%, so that went down to about 2/3. Still had some form of requirement for assistance during mobility. And urinary dysfunction started out at 85%, and chronically about half of them still had some urinary problems on outcome. Yeah? Yeah. Okay, so I think there were two questions. The first question was about the white blood cell count in the spinal fluid, and was the question about adults if adults don't have white blood cells in the spinal? Pretty much always there's an elevated white blood cell count. In children, no, because and especially young children. But that's one of those things where you have to look at the age of the child too. So the really young ones, as Dr. Kerr mentioned, sometimes don't have it, where you'd expect them to have it, but they have other symptoms that are consistent with inflammation. Okay, so in those individuals, you really can't go by the spinal fluid count. But if you were looking at it as a group, because these are all group numbers, the ones with a lower elevation in central spinal fluid, white blood cell count seemed to do better. And the other question about the bladder not growing well, I'm not sure what she meant by that. I think that if you don't have stimulation to the bladder and it's not filling and emptying on a regular basis the way that it normally should be, you might have some shrinkage of the bladder itself. So that might be what she meant by not growing, but that's related to the urinary problem from the spinal cord injury itself. You mean overall? I'm sorry, say it again? Okay, right. So the question is basically, is the prognosis worse for children than it is for adults, and could you die from TM? The answer, unfortunately, to the second part is yes, you can die from TM, and I think we have, maybe two fatalities in children with the diagnosis of transverse myelitis. So that is unfortunate. And overall, I would say that the prognosis, the surprising thing to us was the prognosis in children that we found was worse than what was previously published for children. And I think slightly worse than what's been previously published for adults as well. Okay. So in conclusion, what I'd like to just say are these three things. Uncomfortable sensory sensations suggest that management of ongoing pain is an important part of long-term management of children following TM. And I think I could probably say the same thing for adults with TM too, that this is an area that I think requires focus and a variety of treatment options. And I think just because it's a child with TM you don't need to look any farther than it can be related to the transverse myelitis, and you should think of things to do to manage that. Although shorter time to diagnosis was associated with better outcome, this finding requires cautious interpretation because we do not know the relationship between early treatment and subsequent skills. There's a lot of work that needs to be done in trying to understand the best way to treat transverse myelitis. And the effects of initial intervention on outcome and the effects of rehabilitation intervention on outcome are two areas that require further study. So this is still a work in progress. We're still understanding, what causes transverse myelitis, but on the rehab end of things, we're still looking at a variety of different interventions, a variety of different exercises, a variety of therapy approaches. Exercise bicycles are one example for that have been tried. A variety of ways to manage spasticity in children, oral medications versus intrathecal medications, which is medicine that you put directly into the spinal cord for managing some of these symptoms. There's a lot of things that we don't know about the optimal way to treat the problems related to transverse myelitis, and I think that's a very important area for us to do research in. One problem there is a very difficult area to do research in because you really need to treat every child as an individual, every person as an individual, obviously, and you can't do these group studies where you will treat half of them with a rehab technique and not the other half, and compare the two. I don't think that's ethical. Okay, so in closing, I'd like to thank Sandy and the TM Association for asking me out here so I could get away from the hot and humid East Coast July that is waiting for us from the East Coast when we get back. Those of you who see this picture recognize this is sort of a hot, sultry day on the Chesapeake Bay. So thank you very much for your attention.